Want a podcast that actually helps you feel better this time of year? How about you add well to the beach bag? All summer long, myself, Claire Murphy, and the good Dr. Mariam will continue to bring you fresh episodes and interviews with incredible women like Paralympic swimmer Katja Dedekind, who says her visual impairment is nothing compared to the other medical conditions she's been dealing with. Plus, we'll have a stack of no-nonsense health advice from unpacking this incredible phenomenon known as poo euphoria to how alcohol hits different across your menstrual cycle. Ladies, it's your full body health check on holiday mode. Well, listen now wherever you get your podcasts.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And welcome to 2026, Pat.
Woo!
Woo. We had a little break and we thought everybody could have a little break from us.
That's good. And we're back today talking about, fertility.
Yep.
Natural, normal fertility.
Yeah.
And the role of hormones.
Yeah. So we hope you had a really good break. And we know why we really wanted to do an episode like this because the New Year's resolution or, people go, okay, well, like this year is my year for getting pregnant. So we do know that people pick up our podcast at the start of the year because, that's on their agenda. They want to get pregnant. Good. So we've called this hormones, fertility and all the buzzwords because as soon as they start wanting to get pregnant, they get onto their social media.
Yeah.
And they hear a lot of things that is a bit confusing.
Yeah, and this is one of those areas where the information available through sort of social media and online is often problematic. There is information out there that's just, incorrect, factually wrong. And then there's information that is accurate or contains at least a kernel of truth but lacks context and is difficult to understand without expert knowledge.
I know, and there's just terms that we want to explore, but you see it all over TikTok and Instagram, and it sort of just is part of that confirmation bias, isn't it? So you see something again and again and again because that's what the algorithm is feeding you, and then all of a sudden you think, well, this must be true.
Yes, so people often don't realise that that's what's happening, that they're reading the same thing over and over and over, and the fact that it's not accurate doesn't matter. We're not very good at picking that up.
No.
If we read something several times, there is a bias in our brains that just assumes that there's something to it because we've seen it a number of times. But that actually doesn't change whether it's true or not.
And we had this around the dinner table one night, didn't we, when the boys were talking about a sign of, what was it, iron deficiency, was fainting or something?
Yeah, that sort of feeling lightheaded when you lifted your hands above your head was a sign of was a common sign of iron deficiency in young men at the gym. And I said, I don't think that's right. and they was, oh, no, it must be. And I said, well, why would men be iron deficient in the first place if you had plenty of iron in your diet and you don't menstruate? Well, that'd be pretty uncommon. And there was this sort of silence and everyone went, yeah, okay, that's probably...
That does make sense.
Yeah.
And what was their solution, Pat? Do you remember? It was us you should say that on TikTok.
Oh, right, yeah.
We're not even on TikTok, but, there we go. I know, Pat, we've done it before, but I think by setting some context here, let's do a 101 about hormones and what actually runs the menstrual cycle.
Sure, that's we're sort of going back to that high school diagram of the menstrual cycle. Nothing's changed. Nothing's changed. The first day of bleeding is day 1. At that stage in the menstrual cycle, both estrogen and progesterone levels are low, as well as FSH and LH, the hormones from your brain. And during basically the first half of the menstrual cycle, the estrogen is being produced within the ovary preferentially, and that helps thicken and improve the uterine lining in case a pregnancy is going to implant. In the middle of the cycle, there's a surge in the brain hormones that help the ovary pick an egg and pop it out. And the egg is then available to be fertilized. And in the second half of the menstrual cycle, the corpus luteum on the ovary produces progesterone, and that helps to stabilize that thick lining. And right at the end, the hormone levels drop back low again. The lining disintegrates and comes out as a period, and the whole thing starts again.
And people will know the terms luteal phase and follicular phase. When are they happening?
Yeah, so the follicular phase is at the start. That's when the ovarian follicles are active, and then eventually one gets to release an egg. And then luteal phase is the second half, where progesterone is the predominant hormone.
Mm-hmm. All right. So I want to go through the first buzzword, and you have heard this in the clinic as well. So the first buzzword we want to go through is estrogen dominance. What does that even mean, and what do people commonly blame it for?
On the socials, it's sort of blamed for everything, and it's used as a term as if it has a strict scientific meaning, which I don't think it does. Needless to say, there are times in the menstrual cycle where there's estrogen dominance, but that's normal. And so the first half of the cycle is characterised by higher levels of estrogen and lower levels of progesterone. And of course, that's perfectly normal. There probably are some conditions, real conditions, that are captured by this idea of estrogen dominance, and maybe that's what is meant by the phrase. But they are pathological conditions which people are likely to know whether they already suffer from or not. For example, in polycystic ovarian syndrome, PCOS, the ovary finds it very difficult to find a follicle suitable for development, maturation and ovulation, so there is no ovulation in a severe case. And the second half of the cycle doesn't have enough progesterone, and the continued dominance, if you like, of estrogen can cause problems with the cycle being irregular, very long, not happening at all, or the eventual bleeding being very heavy. And I've always thought that scenario would be better described as a progesterone deficiency than an estrogen dominance, but that's neither here nor there. Other conditions where estrogen dominance would be a real thing would be, say, the postmenopausal woman who's overweight. She's making estrogen in her peripheral fat cells that can stimulate the uterine lining in an unhealthy way, a pathological way, after menopause, enough to cause a postmenopausal bleed, enough to thicken the lining and cause a bleed. And because she's no longer ovulating, that's long since stopped, she doesn't have the progesterone phase, so she's not getting the thickness of the uterine lining is not just causing a benign bleed. It can get thicker and thicker and stay thick for a long time and eventually develop precancerous or even cancerous changes.
So do you ever treat estrogen dominance?
Well, I don't call it estrogen dominance to begin with, but yeah, of course, we treat all of those things. So, for example, the woman with PCOS, and of course, it entirely depends on what she's trying to achieve. If she wants to be pregnant, then we focus on treatments that induce ovulation, so that we can get her, if possible, ovulating each month and pregnant if that's her goal. And of course, that not only sort of fixes the cycle. If you ovulate, then you do make your own progesterone, and the next period will come at the right time and be the right volume. But of course, the idea is to get pregnant quickly, and hopefully we don't need to do that treatment too many times in a row. Because if the treatment's working, that woman's at the starting line like everybody else, and she can hopefully get pregnant quickly. If the idea is just to normalize the cycle, then there are two ways of putting the progesterone back in artificially. The pill does that pretty well. It's not for everybody, but the pill hormones can take over from the fact that we're not producing our own sufficient amounts of progesterone in the second half of the cycle. and sort of mimics a textbook ideal cycle. And then the Mirena system does that quite nicely as well. It just puts some progesterone in the uterus for as long as the Mirena is in place. This is the progesterone-containing IUD, and it puts the progesterone straight into the lining, and that works a little differently. It can make the lining nice and thin and very stable, and using that system, you can get down to either a very light period or none at all, which most women if they've got PCOS that causes them to have highly irregular, big surprise periods of really varying volumes, then most of those women would prefer to have nothing. No period. And that's where those IUDs can be very useful.
This is interesting. So, people on the internet are talking about estrogen dominance, but you've already said that it's perhaps a progesterone issue. And then that's the next sort of buzzword is the low progesterone. Everybody wants to know, have I got low progesterone? Mm-hmm. So that is a thing.
Having an insufficient amount of progesterone in the second half of the cycle is a thing, but it's really a thing that is most commonly encountered in a fertility investigation setting. So there is a thing where you ovulate, but you don't produce quite enough progesterone in the luteal phase of the cycle, the second 2 weeks, to fully sustain the lining in a way that will allow an early pregnancy to implant. And that is occasionally a real thing that needs treatment. We sort of concentrate on luteal phases that are shorter than 10 days. So that's if you ovulate on day 14 and then the new period has come again by day 24. It's a bit short. And putting progesterone in the form of vaginal pessaries can be quite useful for that woman. But typically, by the time we've got this far down the investigation pathway, that treatment would be taking place within a investigation of infertility or management of infertility setting by some sort of expert clinic who would be very experienced in doing that.
So you've sort of stolen my thunder with the next buzzword, which is the short luteal phase, but it seems like we can't separate the two. But what are the signs that, let's go back to low progesterone, what are the signs that somebody might have low progesterone?
Well, it's really just that the cycle would be too short.
Yeah. So they've got onto their tracker, or they've just got the old paper and pen out and they've started to do cycle day 1.
Yeah.
And then they've found that they're bleeding too early. So the whole cycle's too quick. Yeah.
So what we want to do in that situation is work out whether this is an ovulatory cycle. There's been no ovulation at all, which has causes X, Y, Z and treatments A, B, C, or whether it's a cycle where the ovulation has happened, but the luteal phase, the post-ovulation phase, is not long enough. And that's a different phenomenon with different treatments.
Hey everyone, Mons here. If you don't usually listen to parenting podcasts, we'd like to change that. Parenting Out Loud drops fresh eps every Saturday morning. We look at the trends, the news and the culture, all through the lens of being a parent. Because when you have kids, you get a front row seat to the world and you see it just that little bit differently. This summer, join the conversation, laugh, think, and know you're not alone in noticing it all. Head to Parenting Out Loud on your favourite podcast app and get your summer listening sorted.
So talking about low progesterone, so lots of social media talks about progesterone testing or supplements. Is that helpful? Is that actually a thing as well?
It's not something that we need to be concerned about if the cycle is normal.
Yeah.
Okay. So if we ovulate and there's a confirmed ovulation, ideally with a day 21 progesterone test, and we know that the woman is ovulating, and yet the cycle seems way too short, then that's something that needs expert management. If the woman ovulates on day 14 and the new period comes on day 28, that's a normal cycle and it doesn't need investigation or management. Yeah.
You mentioned day 21 progesterone test. Like, just in case somebody's picking up this episode for the first time, can you just describe what that is?
Yeah, it's a blood test that can be done on day 21 of the cycle. And when we say day 21, I guess what we mean is a week after expected ovulation. So let's say, for example, we've got a cycle that varies in length between 28 and 31 days. And we just want to make sure that it's definitely an ovulatory cycle. Then you can imagine that someone who has an average cycle length of 29 days is likely to be ovulating on day 14 or day 15, and you add a week and then do a blood test on day 21. And if the progesterone level is really high, then they've definitely ovulated.
Yeah. And if someone has a cycle that's like 23 days, but it's regular, does that bring their progesterone test day earlier?
Yeah, so that may be an ovulatory cycle still. And what we often do in that situation is use those pea on a stick ovulation predictor kits. Remember, they're a predictor kit. They don't tell you whether you've ovulated or not. They just tell you that the LH hormone has come out of your brain to tell the ovary to ovulate, which is close enough. And it does allow it to be done in a predicting way, which is handy if you're trying to time intercourse. So that it doesn't tell you you're ovulating right now, it tells you you're going to ovulate tomorrow. So you can use those to sort of narrow down the likely ovulatory day, and then you can test at the appropriate time a week later.
Okay. Many sort of fertility influencers do. I want to really talk about the short luteal phase or luteal phase defect affecting implantation.
Yes.
Can you describe what that is?
Well, that's what I was talking about before, when we've ovulated, but we don't have enough progesterone in the second half of the cycle to stabilise and prolong the lining in a way that's maximal for the implantation of a fertilised egg. And in particular, it doesn't last long enough. The new bleed comes, and the pregnancy hasn't had a chance to implant. It's often talked about as if it's really common, and it's not terribly common, and it's something that would be typically managed within an expert fertility service. Sometimes when I see on the socials about progesterone defects in the second half of the cycle, it's talked about as if it's something that might be wrong with you and you wouldn't know.
Yeah.
Right? But that person would have an abnormal cycle.
Right. Okay.
Yeah, most of the time, and that would bring it to our attention, and we'd look into it.
All right. And they are also told that things like stress, illness, travel, coming off the contraceptive pill, which we want to talk about in another episode, can shorten the luteal phase temporarily?
Well, that may be true, and for some of those things, the exact mechanism is known, and some it's not known so well. So, if we look at, for example, coming off the pill, it's known that it takes a few months in some cases for the original natural system that starts in our brainstem and tells the ovary what to do, and the egg comes out to kick back in again. Now, and that's a benign thing for most people. It will come back within a few months. That isn't as common as often it's believed either. If you look at someone who conceives on the pill by missing one, they've ovulated by missing a single pill, especially if it's one of the ones adjacent to the pill-free ones, the sugar pills. So. Some people's are on a hair trigger, and their body will ovulate immediately.
Ready to go.
Yeah, ready to go. Sometimes it takes a few months to kick back in, but that in itself is a benign process. If somebody has been on the pill for a long time, stops the pill, and the ovulation seems to never return, it's common to blame the pill for that. It's not the pill that's caused that. They have an underlying ovulation issue that has that when the pill is removed, it's still there. And the most common scenario for that would be somebody who in fact went on the pill as a teenager for an abnormal cycle, and the pill was very successful in overriding that problem. The problem mostly is PCOS or its variants, and the pill appears to fix that. It gives me a nice cycle as determined by the pill packet, and you might do that from 15 to 30, and then you're ready for a baby. Take the pill away and the cycle's nowhere to be found, but it's the same problem you always had. Yeah.
It's interesting, the psychology around fertility and infertility when it comes to social media, and people having these sort of big blanket statements, and there's a lot of blame that something that the woman's doing is creating the situation, and there's a lot of how do we balance our hormones? You need to go and balance your hormones. What even is that, Pat? Is that a real concept? Is there anything that I can do to balance my hormones?
Yeah, It's an interesting concept, the idea of balancing hormones. It's, if you like, an unscientific concept. It's certainly not a medical concept. I don't mind if my hormones are balanced or not. I don't know what that even really means. What I mean is, what I want my hormones to do is what they're supposed to do physiologically. And if that's what people mean by balancing their hormones, then good. But lots of the hormones in our body don't need to be balanced. For example, estrogen and progesterone working within the pelvis. There's times for estrogen and times for progesterone, and if they were balanced in terms of the levels were the same at all times, the cycle wouldn't work. I think that phrase oversimplifies things. But if people mean how do I get things working as effectively as possible, then probably the thing we see that's the biggest impediment to the cycle working normally is obesity. And there's no doubt that lifestyle factors of managing body weight, alcohol intake and smoking are the things, are your bang for your buck things that you can do while you're trying for a baby. Beyond that, symptoms of significant hormonal disturbance are likely to be symptomatic, i.e. they would create a menstrual cycle that was clearly abnormal. And the trick to that is not to sit there on that abnormal cycle for a long time thinking that you've got condition XYZ because you read about it online. It's to see an expert and get it fixed.
Have it investigated.
Yeah.
Have you seen anywhere, Pat, in any scientific research that suggests that inflammation decreases your chance of implantation?
Experiencing inflammation elsewhere in the body?
Yeah, so in your joints or, yeah.
Yeah. The answer is maybe. If we look at relatively non-specific symptoms like aches and pains and so forth, there are parts of that vary with a normal menstrual cycle. Okay, and so it's not to trivialize the symptoms, but they may be perfectly common and acceptable in somebody in the couple of days before menstruation, and that's something that woman has or always had. If we look at, say, for example, something like joint pains, then that might be a premenstrual symptom in some women, but it might indicate a significant inflammatory condition like rheumatoid arthritis in another person. And that's why I think that if someone has, if a woman trying to get pregnant has a persistent symptom, then bringing that up with an expert is highly recommended, because it's difficult to know as a non-expert what's relevant and what's not. Yeah. Similarly, if we had somebody who was experiencing some of those symptoms but had a textbook normal cycle and a normal day 21 progesterone test and was fine, then we might say, well, that symptom needs symptomatic treatment, use a wheat bag hot pack, take some paracetamol, but it's clearly not affecting your cycle. Yeah.
What about these are the ones that we just have trouble looking at on social media, but like all the pads that are full of brown blood. Do you think brown blood either at the end of a cycle or post a period signifies anything like low progesterone?
I don't think that that's really necessarily a thing at all. I would be looking at the regularity of the cycle, not the appearance of the blood. So, for example, if a woman had a period that was mucky and brown but happened on a perfectly clockwork 28-day cycle, that's going to be normal. If someone has a period that's mucky and brown and happens every 4th month, that's clearly abnormal. But it's more about the regularity than the appearance of the blood.
Yeah.
We're bringing 3 fresh episodes for our But Are You Happy summer series, dropping December 27th, January 3rd, and January 10th. They're all about the big holiday topics, the psychology of drinking and how to resist the pressure to have alcohol, dealing with money stress and reframing your spending so you don't get overwhelmed, and navigating family and friend dynamics at holiday catch-ups, especially when you all have different opinions and beliefs. It's your survival guide from your brutally honest friends to getting through the holidays in one piece. But Are You Happy? Wherever you get your podcasts.
I want to move to the full hormone panel. So before trying to conceive, some influencers are saying things like they need to get their estrogen, their progesterone checked, their LH, their FSH, their testosterone, their cortisol, their thyroid, like the whole lot.
Yes.
From a medical point of view, is that necessary? Have you ever got anyone to have a hormonal panel?
I've had people who've clearly got abnormal cycles having hormonal panels all the time. But this is probably one of the real areas where what appears on the socials and what appears and what's considered good medical practice really clash. Because doing tests to confirm normality is not considered a good idea in most of medical practice. It's also considered a pretty irresponsible use of public money. These are expensive tests, and if we've got someone with a 28-day cycle and no apparent indication of disease whatsoever, it is probably an irresponsible thing to do to spend a lot of money to confirm what we already know. Yeah. So when is the appropriate time to start investigating? Well, it's straight away if there's clearly a problem, or on history examination, talking to the woman, talking to a partner, that there's clearly an issue, or after an agreed amount of trying in a couple with no apparent issues just aren't pregnant yet. Tests up front I have an ideological problem with, because the person is probably, if we've taken a proper history and done an examination, they're probably normal. And those things, for example, if we look at those hormone levels, if the cycle is normal, those hormones are working properly. Yeah.
It's the trust that we have in ourselves to be able to naturally conceive.
Yes, one of the things I think is changing a little bit is that there's a lot about infertility online, and so people sometimes, it's quite common, falsely believe that they are likely to have a fertility issue.
Yeah.
Whereas in fact they are unlikely to have a fertility issue mathematically.
Yeah.
They're probably fine. And people get pregnant every day. So that so the disease processes are the exception, not the rule, and we should probably start off on that basis. Yeah.
And for anyone that's picked up this episode and it's the first time listening to us, we do have a 101 basic sort of, here's your menstrual cycle, ovulation ninja. They're all in our earlier episodes, and we'll put all those links to that. What we really wanted to do in this episode was talk about the times that you're scrolling and think, oh my God, what does that even mean?
Yeah.
Is that something I should be doing? And then all of a sudden you're panicking because you haven't done the proper tests, and are you ready to even start trying? And then that sort of sends some people into a bit of a spiral. So we're hoping to.
When it comes to those tests, you do not need those tests.
Yeah.
What you need is a way to assess whether your current cycle is normal. And that's covered in the Ovulation Ninja episode. One of the first and most popular ones we've done.
Yeah. Because
if your cycle's fine, you don't need a bunch of tests to prove it's fine. You can see that on paper.
Yeah.
Yeah.
Yeah. And that is a sort of a preamble to the next one, which has got a great name, the natural killer cells. So there's content online. They're called high NK cells, and they've been said to attack embryos and cause miscarriages. Is that something that couples should investigate?
Well, this is a really good example of a possible problem galloping ahead of the science behind it, but also being taken up by certain people promoting health interventions online that aren't sort of necessarily backed by evidence. Our blood's got these things in it called natural killer cells. They're part of our immune system, and they're really important in identifying cells that have been infected by viruses, and then the natural killer cells comes along and kills that cell, and that's part of our immune system. Interestingly, some of those natural killer cells exist in the endometrium, the lining of the uterus. And this is a research area. We don't know exactly what the significance of those is. There's a possibility that those natural killer cells may be active in the uterine lining and might actually be activated by the implanting pregnancy, which it recognizes as partly foreign from the paternal DNA, and maybe attacks them, and that might be why recurrent miscarriage happens. The problem with the theory, of course, is we don't know if it's true or not. It's just one of the things that might be true. We don't know exactly what natural killer cells are doing in the endometrium, but it is a problem in search of a solution. We don't know what you can necessarily do about that. If we think it's happening in an individual woman because she's got a really high natural killer cell count in her lining, what should we be doing about that? Treating that woman with cortisone to try and dampen down the immune response? What are the ramifications for that? Does it work? Yeah. So it's a research area. Yeah. Yeah. It's certainly not something that people who, for all they know, have normal fertility need to be too worried about, because it's a research area and certainly only relevant to a couple with a problem.
The next one I want to talk about is the MTHFR mutation.
Yeah.
We have touched on that a couple of times, but, there's a lot of noise out there about women who have been found to have that gene variant need special supplements to help them get pregnant.
Yeah.
What's the evidence actually say about it, and does it cause fertility issues?
Yeah, it's a good question, and it just raises that point that if we read the sort of non-expert literature, the online content about these things, often in the online content there is this idea of the holy grail, that there's a gotcha moment where we go, we found out it was protein XYJ that turned out to be the clincher, and that was the one that was going to help infertile women get pregnant. And it was going to fix women with recurrent miscarriage and so forth. And a few times, even in the expert scientific community, we've thought we've hit it. And most of those things have been disappointing. Okay, like most of scientific progress, it's been a slog over a century with big moments. The invention of insulin, the development of the safe cesarean section, the invention of effective vaccines. There have been some quantum leaps, but mostly it's been a slog of increasing scientific knowledge, a lot of false starts, and then some things that have shown real promise that have eventually wound their way into clinical practice. The online discussions don't seem to have the patience for that, and they're always looking for a breakthrough moment. If we look at MTHFR, we know folate's important for early pregnancy, for the development of the baby's immune system and actually a number of points along the fertility pathway. And some people are very good at absorbing the ordinary form of folate, which is in our pregnancy multivitamin, and converting it into a more active form within our body with an enzyme that works really neatly, that works efficiently. And then there are a small number of people who have a gene that causes a defect in that enzyme pathway, and the conversion of folate within our body is way less efficient. And when this was first discovered, everyone, oh, brilliant, that's probably the problem, fantastic. Turned out to not make a huge amount of difference. The dose of folate in most people is easily sufficient such that an inefficient pathway can still spit out enough of the activated folate, even if it's inefficient. And so for most people, that is not an important clinical issue. Most of the places online that are talking about that being a really important thing are trying to sell you something, mostly an expensive supplement made out of the activated form.
I think everybody could actually take that on board and say, well, if this person is saying that X, Y, Z means that you're going to have a hard time getting pregnant, what is behind that? Are they actually selling something that makes all of that go away? So, just everybody has to have their feelers out.
Yeah, take a breath and ask.
Yeah. Are they selling something? I've got one more. I didn't even know about this, but in my research of Instagram, I found that a endometrial receptivity assay is being promoted as a way to find your personal implantation window and improve IVF success.
Improve IVF success.
Yeah.
I hope it's not being promoted to people outside of an IVF cycle.
No.
Yeah. What what this is you can run a sort of a mock IVF cycle where you set yourself up, but you don't intend to get eggs and actually implants. You just want to work out how to get the lining perfect and how to get the lining the most receptive, in quotes. So you run the cycle as a mock cycle, and then you take a couple of biopsies from the lining to try and work out where the perfect day in a real cycle to put the embryo in. That's what that is. You're taking a biopsy and you're trying to work out, should we be putting, when we run a real cycle, should we be putting in the embryo on day X, Y, or Z? But this is all part of IVF stuff. This doesn't have a role outside of the outside of IVF.
Good. So just delete that from your list, people.
Yeah, there's a whole. Anyone who's had anything to do with IVF who's listening to us will know that IVF has suffered a little bit from what we call the law of diminishing returns. They got really quite good at it over the 90s and 2000s, and they're still really good at it. But there are still a small number of people it doesn't work for at all. Now, some of those people are trying to use their own eggs and they're too old, and that's a real problem. Some of the unexplained non-successes, they say, well, have you tried this? Have you tried this? Have you tried this? Have you tried this? And they're called add-ons and they're expensive. And there's a real debate in the fertility community about which ones work and which ones really don't. You can imagine that if a couple have already spent a lot of money and they've had nothing but heartbreak, they will sometimes try anything. And there's a bit of an ethical problem, I think, weighing up which of these add-ons have scientific merit and which are just desperate people who try anything.
Yeah.
And, of course, there's also an important ethical consideration that we don't do things that are harmful.
We might have people who pick up this episode because they've got secondary infertility, and I have promised this for a couple of episodes now, but we do have an IVF specialist coming in to talk to us about secondary infertility too, so we might get onto some of those add-ons.
Excellent.
Now, Pat, I want to end our episode on rapid fire yes or no, which is making me laugh even saying that.
I can't do it. There'll be some maybes or some.
Yeah. So let's see how we go.
All right.
Seed cycling balances hormones.
No. I had to look up what it was. Yeah. So I knew you were going to ask me about that. So that's where you eat different seeds at different times of the menstrual cycle.
Yes.
It would appear to have no scientific merit whatsoever.
Yeah.
Do it if you want. Yeah, seeds are nice. They're good for digestion, but I don't think it has an important role in any of this.
Yeah, flax and pumpkin seeds during the first half, and then sunflower and sesame seeds during the second half. Good. Progesterone cream fixes luteal phase issues.
I'm not aware of it being used for that purpose. We use vaginal pessaries.
Which is progesterone?
Yes. But that's in vaginal tablet form.
Right. Estrogen dominance causes weight gain.
An estrogen dominant condition is PCOS, which involves all sorts of metabolic problems and is commonly seen in women who are, and the patients with that condition are often overweight. Has the estrogen dominance caused the weight gain? I don't know. It's all part of the same syndrome in some people.
Yes.
Yeah. And that person, one of the recommendations would be to decrease body weight. And that's not because the estrogen dominance has caused the weight gain. It's because if we drop body weight, especially if we can drop it quickly, then it can kickstart ovulation.
You can't get pregnant with irregular cycles.
With irregular cycles? No, you can. Some irregular cycles are ovulatory.
A day 21 blood test works for everyone. No,
we would do it when we would expect it to show ovulation. So if someone has a cycle that's 35 days long, but it's every cycle is 35 days long, that's likely to be still ovulatory. But the ovulatory day might be as late as day 21, which means that you would do the progesterone test on day 28.
Yeah. You can boost progesterone naturally.
I'm not aware of a way of doing that.
Good.
Other than weight reduction, restarting ovulation, which would restart natural progesterone.
Yeah. they're my rapid fires. That's all I had for those rapid
Were
fires.
Were my answers rapid fire enough?
Pretty good.
It's not bad for me.
It's not bad for you. I know. This is the thing, right? It's like people want rapid fire answers, but these are nuanced answers, aren't they?
I know.
Yeah.
There's complexity that we shouldn't shy away from.
So we have talked a lot about, the things that won't work. I don't want to leave people there. So I want to talk to our listeners about how to be healthy. How can you yourself have some agency in this to help you have a good menstrual cycle?
Yeah, that's a superb question, because I would love it if a couple who are considering coming off their contraception, they're 29 years old, it's time for a baby, we're going to come off our contraception and try for a pregnancy. I would love it if that couple focused less on the possibility of pathology, which they probably don't have, and more on the lifestyle factors that will promote healthy fertility. So we've covered this elsewhere, a bit of a checklist for a pre-pregnancy thing, but the big ticket ones are, if either of you smoke, you stop. We want to reduce alcohol intake, and we want to optimize body weight, not just to get pregnant in the first place, but to have a healthy pregnancy once we're pregnant. We can have a bit of a look at our cycle and work out if it's regular or irregular, and a visit to the doc before we're pregnant is a great idea for 3 reasons. Do we have, or are we likely to have, the wherewithal to get pregnant quickly? Ovulating, normal sperms, and a safe place for them to get together inside the woman, and we look for symptoms that some of those things might be wrong. Irregular cycle, lots of pelvic pain. 2, any conditions that we've already got, we want to have the management of those conditions optimized. And lastly, we can do a pre-pregnancy genetic screen to make sure we're not a carrier of important genetic diseases. And that's where the focus should be.
And that, just a reminder, everyone, that 3-panel carrier screen that Pat just mentioned is now bulk billed in Australia. So
how sweet is that?
That's great. Just
uptake. I've just noticed a massive increase in uptake when it doesn't cost $300 or $400. This for something that you probably don't have. So it's way easier for people to go, yeah, fine, I'll have one if it's covered.
And there's other things people can do, like, sleep is becoming so much part of the biohacking now. Like, make sure you're getting good sleep, whatever that means for you. Good
Absolutely.
Sleep. Yep. Reducing caffeine, reducing alcohol. And you mentioned smoking, but also vaping. There's so many younger people that vape and all of that. Yeah,
things that have got a really, really strong evidence base that if addressed in advance, you'll go better.
Yep.
Focusing on pathological causes of subfertility that you probably don't have is not the best bang for your buck before we get started.
Yeah.
Yeah.
So that's all the buzzwords I've got, Pat.
Well, that's good. I think we've done well, and I think it goes back to that original message that the internet is often not a reliable source of health information for the reasons of some of it's inaccurate and some of it lacks context. And I hope today's been useful for people to dispel some of those problems.
And give us some feedback. If you've got a buzzword that you've seen online and you think, oh, hang on, they didn't cover that, just send us a DM on the Kick Pregnancy Podcast on Instagram, or you can even email us at info@growmybaby.com.au. We would love to know, and we'd cover it in another episode.
Absolutely. I would more than happy.
Yep.
Yeah, this is about education, and it's about democratising the process of improving people's knowledge.
Yeah.
And more than happy if someone says, I've read a lot about this, is it something I need to be concerned about or not? Run it by us.
Yeah, because we understand rabbit holes. I go down a few myself, don't I? All right, everyone, thank you so much for joining us with our first episode for the year. We've got lots of great episodes planned in this first couple of months, so we look forward to being on the journey with you. And as I always say, until then, we'll be back in your ears in a week. Keep well, keep growing your babies, and we'll see you then.
All the best, everybody.
Bye for now.
Hey, even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.